The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanic, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Hello, TMD warriors. Good day, good morning, good afternoon. I'm Tony Urbanic, and we are gathered here for the next episode of TMD Demystified. Today, we're going to discuss the topic of TMD, a case of the blind leading the blind. And we'll probably also throw in a little bit of the need for TMD to be addressed and treated standardly. We'll kind of bring that in the middle of it here. But today is a Tuesday morning, and I'm on a short schedule. I'm seeing patients today, and I have just a short time to do this video in between my need to see patients. Got my patient doctor uniform on today. So let's get into this topic a little bit and tell you what I mean by the blind leading the blind when it comes to treating TMD. You know, generally speaking, our healthcare system is a very complex system. I don't think anyone would disagree with that. In fact, so complex that no one can quite figure it out. And the politicians are the people who direct healthcare for many different aspects, large organizations, hospitals, large physician or dental organizations, the ADA, the AMA. They all have a different point of view on what should be done from their point of view. And this is the first point I want to try to make when this applies to TMD, and hopefully stick with me and I can make the point here. But first, I just want to describe the general nature of the problem and then apply it to TMD specifically. So the general nature of the problem, as it applies to now healthcare in a general way, I think this whole concept can be applied to any other concept of human endeavor, transportation or large organizations, retail organizations. But let's just stick to healthcare because we're all involved with healthcare, and then we'll bring it into TMD specifically. So as it applies to healthcare, there are organizations and people and groups that have a part to play in it, generally called folks who have an interest or and let's just say an interest, but they each have a different point of view. Let's just go through. The insurance companies have a different point of view about what they're trying to accomplish. We covered what insurance companies are all about. They're there to make a profit. They are not necessarily there to help, although that's their PR, but they're there to make a profit. I'm not going to try to beat up on insurance companies, but that's their purpose. The AMA has a certain purpose. Their purpose is to gather physicians with medical degrees and get them coordinated just as a union. Basically, the AMA is, although it's not a union, it is similar to a union in that it has power and it has a voice and it has a megaphone, and it uses that to direct and organize the group of physicians. Same with the ADA, exactly the same. Large hospitals networks have a point of view. Hospital networks are there to make a profit. And if they don't make a profit, they won't exist, and then we won't have hospitals. On the other hand, They're there to organize for their purposes and bring in people that they need to employ in hospitals. But the point is that each of these individuals or groups or organizations have a specific point of view of which they operate from. And the point of view can change depending on circumstances or time. A couple of these organizations will come into conflict with one another because they have different points of view. Regarding TMD, it is a disease of which every one of those organizations may not have any interest at all, or may have a deep interest. Let's pick it apart here. So that AMA probably has no interest at all in TMD. Just from a very, very distant, they know it exists, but that's somebody else's problem, not ours. The ADA has a vested interest in it, and they just approved a specialty for the treatment of TMJ, TMD, or facial pain. They just put it into a general category of facial pain. On the other hand, but they can't define it very well. What is facial pain? That's the problem. Every individual doctor who sees TMD as an individual or their practice has a point of view about the problem. We already talked about half the dentists in the country don't want anything to do with TMD because they know nothing works. It's a Pandora's box. It's a bag of worms. And half the dentists in the country use a night guard and tell the patient it's TMD treatment, which it's not. And then there are TMD gurus. That's the 1/10 of 1% that hold themselves out as to be, the specialist in TMD treatment. But the point, again, is that each and every one of those individuals and groups, and then there's insurance companies, have a different point of view. The insurance companies really wish that TMD did not exist because of the confusion and the fact that everybody knows nothing works, and that there are surgeons like myself who for 36 years put in claims to do TMJ surgery and that were not desired, for sure, rejected frequently, and attempts to limit it in multiple ways went on for decades. Again, because they have a point of view. The insurance company's point of view, they're there to make money, and if they start approving or just generally approving all claims for TMD, then and it's not well defined, how can you administer something that doesn't even, it has no known success to it, reproducible success, and you can't even fully define it? That is, I'm defining the problem, and maybe not very well, but I think you hopefully get the point. So let's start out with just a couple definitions and put a little groundwork there so we can build on this, and then I'll make the point. As to the blind leading the blind in the effort to treat TMD. So via the Oxford English Dictionary, just looked it up, defines disease. We're going to start general disease. A disease is a disorder of structure or function in a human, animal, or plant, especially one that produces specific symptoms or that affects a specific part. Definition number one. Definition number two, a quality or disposition that adversely affects a person or a group. This is derived from the Old French disease, which means in French, lack of ease. So all that being given you directly out of the dictionary is that a disease of any kind is basically a lack of ease. A lack of ease. Now, a lack of ease for one person may not be a lack of ease for another. I'll give you, multiple examples of that. But, an individual, I see it all the time here in this practice, what patients come in with a litany of TMD symptoms, but some of those symptoms are not important to those patients. They're not a lack of ease for that patient, but their headache is a lack of ease, so they focus on the headache. And their shoulder pain, which they have, it's not that bad, or they can live with it. And so is that actually a disease for them? Because it doesn't impinge on them. It's not a disorder or structure or a function in a human that produces a negative effect adequately. Well, here's my point about all this and TMD. The problem in solving this problem, as I have solved it and went through the process, is that everyone is operating from their own point of view and not the point of view taking into consideration all the points of view that are available. Because like I said, insurance companies have a different point of view. Not that you don't have to argue with the person because they have a different point of view. You just have to see their point of view. You don't have to accept their point of view in your arena or whatever you're trying to do, but you do have to acknowledge their point of view and understand their point of view from their point of view. So we have as an example, with TMD, you have the ADA, and you have the TMD gurus, and you have insurance companies, and you have patients, and you have doctors who have patients who come in with TMD but may not want to treat them, and then you have doctors with patients who have TMD and they give the patient a night guard, pretty much knowing that that is not adequate treatment or appropriate treatment, and wishing that the patient doesn't come back. Basically, that the TMD is a conundrum. And treating it haphazardly is, just smoke and mirrors. And then you have doctors in different professions who treat the symptoms without knowing where the symptoms are coming from. This would apply to physicians. Talk about that a lot. I can speak on that with some authority because I communicate with my physician colleagues. Again, they don't really want anything to do with it once they recognize what it is, but frequently the problem with physicians is they do not recognize TMD, and they have a patient with a bad headache, and they call it migraine headache, and they give the patient drugs for their migraines. Or if you're a physical therapist and the patient is complaining of upper back and shoulder pain, then they do physical therapy or dry needling. That's the physical therapist point of view. All right, so hopefully I made my point about this, and the point about points of view and the success that I was able to accomplish with what I investigated and reviewed and found the actual solution for was based on understanding each and every one of those points of view. Not that I agree with their points of view. Obviously, I disagree with the majority of the points of view that are out there regarding TMD. But the problem with the solution and finding the solution with TMD, that until my work, I'll take the abuse if you want to criticize me for taking responsibility or saying that I was successful, and I have to say I'm successful because our stats prove it. Our statistics prove that we have seen thousands and thousands of people and solved this problem for these patients. And of course, the independent university study that we do based on 3,000 that we did on 3,000 people, independent. It just here's the patient, do the survey, do the study, see what you find, and which confirmed the success of what we do. But the point is that unless an investigator is willing to actually look and understand all the different points of view, you're not going to come up with an answer, because to be aware of all the points of view gives you vision. And if you only look at something from a limited point of view, you are blind. You are blind to the rest of the things that are out there. And you cannot expect to find a solution if you only look at the problem from your point of view. So I started out my investigation better than 12 years ago now without a point of view. I had a point of view while I had a definite point of view as a practicing oral and maxillofacial surgeon applying surgery to the treatment of temporomandibular joint symptoms. And my point of view was right out of the textbooks, right out of the congresses, right out of the meetings we had specifically for the treatment of TMD surgically. And if it wasn't surgical treatment, it didn't exist. It wasn't important. It didn't hold value to me. And that's the way it was for 36 years. And I fully admit, for the first 36 years, I had the blinders on, only looking at the problem from a surgical point of view. But when I decided to do the investigation, a good investigator will look at all the points of view and not be biased. Or maybe you want to use the word bigoted, biased or bigoted in one particular area, and saying there's really only one solution to this. Why? Because that's what I do. I have a hammer and everything looks like a nail. Well, when I started this investigation, I intentionally, obviously, deleted the point of view of being a surgeon and began to look at the problem from everyone's point of view. The providers, the networks, the people who had a stakeholder, hospitals, insurance companies, patients, doctors who wanted to treat it, doctors who didn't want to treat it, physicians who knew nothing about it, physicians who misdiagnosed it constantly, were not aware that they were misdiagnosing it. Well, all these things came to light. All these came to view as I began looking around without my own point of view to blind me. And admittedly, as a surgeon, I was blinded to the other points of view. I didn't take them into consideration. But as I began to take them into consideration, the whole conundrum of TMD began to be, if you can clear up a conundrum, began to be very clear. And it was very obvious to me, because I had no specific point of view. I could see what worked, what didn't work, what the points of view were that had validity, and the ones that were just smoke and mirrors. Just smoke and mirrors. But directed from that particular group person's point of view. But it made that person, insurance companies were blinded. They didn't want to cover it. They were losing money on it, so they weren't going to cover it. They didn't want anything to do with it. The general dentist who had experienced things he'd done in the past doesn't work. Well, he's not going to want to do things that don't work. So he's blinded. He just says, I don't want anything to do with it. So in that case, in this particular problem, this particular disease, and there are other diseases this would apply to, there are other things in the world that this would apply to, but in our case, this applies to TMD. It came out as the blind leading the blind. You can't describe it effectively in any other way. And if you're blind to other points of view, if you're blinded by your own point of view, you're not going to figure it out. So, if you want to hear the whole story, if you want to hear the backstory, they're on other episodes. I'm not going to go over that with you, but basically, I came out of the box without any blindness and began working literally with the problem itself, which were the patients with the problem, and with a short number of interviews, found out that the patients gave me the key as to where to look, which is they kept saying, if I put my finger, my tongue, a pencil eraser between my front teeth, it feels better. And from that, the whole thing unfolded. I was able to do that. It worked. Then I had to figure out how and why it worked so well, which is in multiple episodes, but it all boils down to inflammation within the temporomandibular joint, and that the muscle activity does not drive the symptoms. It all boils down to the root cause of TMD being inflammation within the temporomandibular joint. And I learned that by starting the investigation with no blinders on, with no specific point of view to prove. And I was not blinded. But historically, up until now, that is exactly what has happened. Exactly, precisely what has happened with TMD, TMJ, and that it was the blind leading the blind, because everyone was operating only from their own point of view and not trying to understand the other points of view. Whether you agreed with them or not was not the issue, just understanding what their point of view was. And of course, when you interview enough patients with this problem and not shun them, not say, I don't want anything to do with this. When I began interviewing patients and doing consultations with patients and listening to the patient's symptoms and their point of view on it, I learned a tremendous amount about this problem. I learned that the symptoms were not just limited to the temporomandibular joint or facial area, that they extended well into the neck and the upper thorax, and included arm, hand, finger tingling and numbness. Found out that the vast, a great, I won't say majority, but a vast number of patients who came in with obvious inflammation and symptoms of inflammation within the temporomandibular joint and bad headaches were being treated for migraines, which weren't caused by anything other than the inflammation within the temporomandibular joint. They didn't have migraines. Whatever that is, we've already covered that the science on migraines admits they don't know what causes migraines. Opens up another area of investigation. So, historically, from the very get-go, from the time that the treatment and the responsibility for treating this joint was given up by the orthopedic surgeons. The orthopedic surgeons don't want anything to do. They're joint surgeons, but they don't want anything to do with this joint. Didn't want anything to do for decades about this joint. I wish they had. I think that the orthopedic surgeons had kept control of this joint, they would have already figured out that this joint is no different than the hip and the elbow and the knee, and they think about it the same way, and they know the pathophysiology of joint problems and applied that pathophysiology to this joint long before it was applied by a doctor who had both a dental and medical degree and a vast interest in facial growth and development, and temporomandibular joint is the primary mover of facial growth and development. So I think I've made that point pretty clear, and I just want to finish it up talking about this second concept, and that is, now that we know really what drives all the symptoms, which is inflammation within the joint, and the most obvious and the best way to decrease the inflammation in the joint is to unload a joint, and unload this joint just like a set of crutches would unload a knee, and ameliorate the knee symptoms. If you had a bad knee and it hurt all the time and you got on the crutches, it wouldn't hurt. So that's the mechanism for this pull it out here, this device, which fits in the roof of the mouth. Once that's been established, then it's a matter of what's necessary to treat this problem standardly. How do you get across the fact that what is out there currently, and today's date is the 19th of December, off my days, 19th of December, and as of the 19th of December 2023, there is no standard treatment for TMD for various reasons. Part of it being that there's blind leading the blind. Part of it being that no one knows what to do because they think nothing works. Part of it being that there are TMD gurus who have a very, very narrow point of view about what they've been taught or what they believe, and they won't look elsewhere. But there is no standardization, and that is the objective, is to put a standardization on this problem. Like any other disease, I mean, if a physician is treating diabetes, there is a standard treatment for diabetes that you don't go outside the standardization. And if you do, not very far. As a surgeon in doing orthognathic surgery or cleft palate surgery, especially orthognathic surgery, there was a standardization for how to take somebody's facial skeleton apart and put it back together. And as time has gone on, because I was in it from the very beginning, from the very inception of that science of cutting the maxillofacial bones apart and putting them back together for various reasons. The standardization got even more standard as time went on, of which, what was standardization? Well, we learned that if we did it this way, it always worked. And if we tried to go outside the standard, we created problems for ourselves surgically and for the patient. So TMD needs a standardization, and it does not have a standardization. And the standardization is only going to be derived, first of all, from the awareness by all the stakeholders that I just previously mentioned, the ADA and the dentist and the physicians, and especially the TMD gurus who use all number of things and throw them against the wall to see if they can work. But the standardization is only going to begin to be standardized when the root cause of all of the symptoms is acknowledged. And from then on, then a standardization can be derived. Now, in our case, with our company, TMJ Services, we have standardized the treatment for not only our practice, but for the other doctors in the network who are licensed to use the device and protocol. And we've standardized it to some degree. There needs to be more work on it, just like there was more work necessary on the standardization of orthognathic surgery. So there's more work to be done, but the standardization of orthognathic surgery had certain parameters to begin with. And in this case, TMD has the parameters that the beginning parameter is inflammation drives all the symptoms, and then standardize unloading the joint appropriately with a device under the circumstances that are available. I only say that for effect because we do have a standardization for the doctors that is based on the standardization that we use in our practice, and that bleeds over or taught by to the other doctors in the network, a growing network of doctors throughout the United States who use the device and protocol and can tell the patient truthfully that if you do the standardization, if you use this standard device and then use it according to the protocol, which is a standard protocol, you will get a standard result. There are exceptions to every rule. There are nuances that need to be known. Again, I've discussed them thoroughly. Vertical dimension has a lot to do with how much force you can put on the joint by the anterior teeth. But as a standard rule, there are exceptions to every rule, but as a standard rule, if you follow the standards, you will get the same result 90+% of the time. And when you don't get the result, then the nuances come into play, and we discuss and can teach exactly what you're looking at, the things that are outside the usual expectations. As an example, there are some people that can put so much force on their front teeth because of the size of their jaw or the lever arm of the mandible or the size of the muscle that can exceed the forces necessary to decrease the inflammation in the joint, at which point there's a solution to that because you understand vertical dimension. Or another example of that is patients who have the habit of protrusion. I have a whole episode on protrusion and the effect that that has on protrusion of the mandible, pulling the condyle out of the fossa, and that's not a healthy situation, but it can be solved. But they are the minority, the vast minority of cases. The standard case, the standardization of the device, the standardization of the protocol, the standardization of the expectations, and the standardization of how the provider, the dentist, takes the patient through the process has all been standardized already, at least in this practice, and now we're teaching it to others. So honestly, it is no longer the blind leading the blind beginning here in this practice with me, with an attempt to educate and make other doctors aware of the progress we've made on treating this disease, which is tremendous. I have a busy day today. I have lots of checks and patients to see, plus 4 new consultations. I did 7 consultations yesterday. I have to see patients 2 days this week, Monday and Tuesday. And just as an aside, before I finish it up, yesterday I had 3 middle-aged ladies who came in without any further direction from me, went on to tell me how many doctors that they have seen and kinds of doctors. The first woman I can recall sat down, of the 3 yesterday, sat down. She's just started to reel off, I am here because I heard that you have a solution for this problem. I have seen everybody. I have done orthodontics. I have done drugs. And she reeled off 3 or 4 drugs that she was placed on for her symptoms. I have done dry needling. I have done chiropractic. I have done physical therapy. I have talked to a psychologist. She reeled off the whole thing. And I was sitting there stunned. I was, yeah, I'm familiar with this. I'm very familiar with this. The blind leading the blind and people not knowing what to do. So they just do anything that sounds good. This is my life. All right, enough said. If you'd like to join the network, if you'd like to learn more about this, if you'd like to apply this to your practice and expand your practice treating temporomandibular joint disease successfully with a standard and able to understand the other points of view, you don't have to agree with them. I don't agree with the majority of those points of view at all, but I do understand them. I understand where they're coming from and how it all fits together to create the conundrum, to create the bag of worms that we're left with here. And it allowed me to look at the actual solution. And when I saw the solution, it became obvious. I mean, observe the obvious, obnosis, observe the obvious. It worked. And then we had to figure out how it works. So if you'd like to join the network, you can do that several ways. You can contact our Director of Operations, Dr. Naomi, and she will give you all the information you need to join the network. You can also take the course and join the network off our website, www.urbanictmj.com. And I'd like to communicate with you. If you'd like to communicate with me, I can be reached at tony@tmjservices.net. So if you'd like to do that, or you'd like to criticize, that's okay too. I will communicate with you if you'd like to criticize me. But until next time, I look forward to coming up with the next episode. And I hope that you have a successful week. And I hope that when you run into patients, whether they be your patients or see people who stumble in the door with some of these TMD symptoms, that you can provide a successful, adequate service for them that will be satisfactory for you and your patients. Till next time, I'm Tony Urbanic, and this is TMD Demystified.